All right, hello and welcome. Today we're going to build a really clear, practical pathway for managing lipids in our patients with peripheral artery disease. It's all about taking the latest evidence and guidelines and turning them into something we can actually use to protect both their hearts and, crucially, their limbs. So let's get right into it. Okay, so here's the plan. We'll kick things off by talking about why PAD is a dual threat. Then we'll dive into the big trials, figure out what the guidelines are actually telling us to do, and then build a step-by-step algorithm you can use in your clinic. We'll put a special focus on limb outcomes and then wrap it all up with some key takeaways. Sound good? Right. First up, PAD, the dual threat. We really need to understand why aggressive lipid lowering is, well, completely non-negotiable. Let's start with the scale of this thing. We're talking about over 230 million people worldwide. That's a staggering number. For every single one of those patients, getting their lipids down isn't just a nice to have, it's an absolute must. And we're about to see exactly why. So let's just pause for a second and ask a fundamental question. When you've got a patient with PAD sitting right there in front of you in your clinic, what are we really trying to prevent? It sounds simple, right? But the answer gets to the very heart of the high-stakes game we're playing with this disease. And here it is, the dual threat. On the one hand, you've got MACE, major adverse cardiovascular events. We all know these guys: heart attacks, strokes, cardiovascular death, the usual suspects. But, and this is the crucial part for our patients, they also face MALE. That's major adverse limb events. We're talking acute limb ischemia, a major amputation, or an emergency trip to the theater for revascularization. Both of these are just devastating outcomes, and our treatment plan has to hit both targets, hard. Okay, let's move on to the evidence. How do we build the case for combination therapy? Well, for a long time, statins were pretty much the whole story. They're still the foundation, absolutely essential. But what we've learned is that on their own, they're often just not enough to get our patients where they need to be. And a whole series of landmark trials has really hammered this home, building an ironclad case for using combination therapy. You can really see the story of the evidence unfold here. It all kicked off back in 2007 with the Heart Protection Study, which gave us solid proof that statins work for PAD patients. Great start. Then, things started getting really interesting with add-on therapies. But the real game changer, the moment everything shifted, was right here in 2018, the FOURIER trial. This was a huge deal. Why? Because for the very first time, we had a therapy, a PCSK9 inhibitor called evolocumab, that was proven to cut not just MACE, but those critical limb events, MALE too. That changed everything. And this table just lays it all out so clearly. You see HPS with simvastatin. Yep, it reduces major vascular events. That's our baseline. Then you add ezetimibe and improve it, and you start to see some signals for limb benefit. But then, look at FOURIER and ODYSSEY. With the PCSK9 inhibitors, evolocumab and alirapimab, it's just bang. Big significant reductions in both MACE and those limb events. Now contrast that with CLEAR and REDUCE-IT. Bempedoic acid and icosapent ethyl. For sure, they reduce MACE, but that clear limb benefit, the data just isn't there yet in the same way. The bottom line is this. When it comes to saving the limb, not all lipid-lowering drugs are created equal, not by a long shot. All right, Section 3, Decoding Guideline Targets. So what do the major societies recommend for our highest-risk patients? It's pretty simple, really. All this powerful trial data showing just how much benefit you get from driving LDL cholesterol down has forced the guidelines to get more and more aggressive. Our PAD patients are sitting squarely in that very high-risk box, and the targets now reflect that. So when you line up the major guidelines, a really clear picture starts to form. In the UK, we've got NICE, which talks about getting a more than 40% reduction from where you started. But look at Europe's ESC and the latest ACC consensus. They're pushing for a hard target. Get that LDL under 1.4 millimoles per liter. That's a bit punchier than the official US guideline of less than 1.8. Now, for our really high-risk PD patients, hitting that 40% NICE reduction often means you land right in that less than 1.4 to less than 1.8 ballpark anyway. So no matter how you slice it, the message is the same. We need to go lower. Yeah, and this chart just makes it crystal clear. You've got the 1.8 target, and then you've got the more ambitious 1.4. Whichever one you're aiming for, the international consensus is screaming at us to be aggressive with our paid patients. The old days of start a statin and hope for the best. Well, those days are over. It's just not good enough anymore. Okay, moving on. We've talked about the why, the dual threat, we've seen the evidence, we know the targets. Now for the most important part, the how. Let's build a practical, step-by-step algorithm that you can take and use in your clinic tomorrow. Here we go, the PIAD lipid escalation pathway. It's a simple, step-by-step process. Step 1, the foundation for everyone, is the highest dose of a high-intensity statin they can tolerate, no exceptions. Now, if their LDL isn't at target, and remember, we're shooting for that 1.4 to 1.8 range, you move to step 2, add ezetimibe. Still not there? Step 3, bring in the big guns, a PCSK9 inhibitor like evolocumab or alirocumab. What about statin-intolerant patients? That's where bempedoic acid comes in at step 4. And finally, if triglycerides are still a problem, step 5 is to consider icosapent ethyl. It's just a logical, evidence-backed ladder of escalation. Okay, a few quick clinical pearls to make this work in the real world. First, who do you prioritize for this aggressive approach? Think polyvascular disease, anyone with CLTI, or someone who's just had a revascularization, they go to the top of the list. Next, monitoring. Make sure you check their lipids 8 to 12 weeks after you start or change anything. What about statin intolerance? Before you label them, make sure it's real. Maybe try a different one, like rosuvastatin, before jumping to something like bempedoic acid. And finally, don't be a hero. If you've got a complex case or suspect something like familial hypercholesterolemia, get them to a lipid specialist. Now, for a really important deep dive, especially for us as vascular specialists, let's focus squarely on limb outcomes. We absolutely have to separate the solid, randomized trial evidence from the, let's say, more circumstantial observational signals. It's about knowing what's proven versus what's just suggested. So let's break it down. When you look purely at the top-tier randomized controlled trial evidence for reducing MALE, who's the winner? It's the PCSK9 inhibitors. By a mile. The data from Fourier and Odyssey is just rock solid. Ezetimibe? Well, there's some promising emerging evidence there from Improve It. But what about the others? Statins have lots of positive observational signals for sure, but we're still waiting for that definitive RCT proof for limb events. And for bempedoic acid and icosapent ethyl, right now the evidence for limb benefit just hasn't been shown. And honestly, you don't have to take my word for it. This quote from a recent ACC expert analysis just sums it all up perfectly. It says, currently, the evidence supporting limb outcome benefits is strongest for PCSK9 inhibitors and is emerging for ezetimibe, both showing benefit in RCT data. Let that sink in. That isn't just an interesting fact. That is a practice-changing statement. Okay, let's wrap this up. Time for the takeaways for your clinic. I've got 12 key points here that should really help you change your practice. Let's run through them. All right, here we go. 1, PAD is a dual threat, MACE and MALE. 2, statins are the foundation, but they're not the whole building. 3, aim low. Get that LDL under 1.4 if you can. 4, combination therapy is the new normal. 5, ezetimibe is your go-to second step. 6, PCSK9 inhibitors are third, and they're the champions for MALE reduction. 7, remember Fourier. It's the trial that proved you can hit both MACE and MALE. 8, got a statin-intolerant patient? Think bempedoic acid. 9, triglycerides still high? Think icosapent ethyl. 10, prioritize the sickest, polyvascular and CLTI patients first. 11, check lipids 8 to 12 weeks after any change. And 12, don't fear the low LDL. It looks like the lower the better, and it's safe. So I'll leave you with a challenge. When you're in clinic this week, picture your highest risk PAD patient, the one you're most worried about. Now, based on everything we've just discussed, what is the one single thing you're going to change about their lipid management to better protect their heart and to better protect their limbs? Thanks so much for joining me. Just the usual disclaimer, this is for educational purposes for us as healthcare professionals and isn't individual medical advice. Always check the full prescribing information and your local guidelines. Cheers!